டெஸ்ட் ஹலோ. சரி நீ க்ளோஸ் பண்ணி மறுபடியும் ரீஜாயின் பண்ணு. ம் சரி கீழே ட்ரெஸ் மாதிரி வந்துட்டு இருக்காங்க நம்ம 2 மினிட்ஸ். இந்த ஓட்டிலேருந்து மேலே ட்ரெஸ் மாதிரி வந்துட்டு இருக்காங்க நம்ம 2 மினிட்ஸில் ஜாயின் பண்ணி.
ஹலோ
கேக்குதா பிரவீன்?
ஹலோ
கேக்குதாண்ணா பிரவீன்? கேக்குதா
ஹலோ
பிரவீன்? கேக்குதா பிரவீன்? பிரவீன் கேக்குதா? ஹலோ
ஹலோ
பிரவீன் கேக்குதாடா? ஹலோ செக். ஹலோ
இல்லை இல்லை இல்லை
நீ ஆடியோ மியூட் பண்ணி வச்சுக்க, சவுண்ட் வைடா. ஹலோ செக். ஹலோ நீ பேசுறது கேக்குது எனக்கு.
ஹலோ ஹலோ
டேய் நீ பேசுறது கேக்குதுடா. ஹலோ செக். ஹலோ
ஹலோ
ஏய் பிரவீன் கேக்குதா?
ஹலோ
ஹலோ டேய் கேக்குதுடா. ஹலோ ஹலோன்னு இருக்காதடா.
இப்போ ஜூம்லலாம் ஒர்க் ஆகுதுண்ணா, நேற்று ஒர்க் ஆகுதுண்ணா அது கோயம்புத்தூரில்.
பிரவீன் கேக்குதா பிரவீன்?
அங்கேயும் ஆடியோ இல்லையே.
ஹலோ செக். ஹலோ ஃபோன் சுவிட்ச் ஆஃப்.
அவர் திட்டுவார் பார்த்து சார், இதில் தான் பேசுகிறேன்.
பிரவீன்
மைக் எந்த மைக்கில் பேசுகிறேன்?
ஹலோ செக். ஹலோ
பேசினா எக்கோ
ஹலோ செக். ஹலோ பிரவீன். ஹலோ
அந்த மைக்கில் பேசினா அங்கே எக்கோ. நேற்று கேட்டுச்சு, நேற்று நானும் இது 20
ஹலோ ஹலோ
கோயம்புத்தூர்லேருந்து வாங்கி கொடுத்தாங்க அம்மாசி பையன்.
ஹலோ
எல்லாம் முடிங்க, முதல்ல இந்த கேஸ் முடிங்க.
ரெடிங்க சார் வந்துட்டாங்க ரெண்டு. நீங்கள் வாஷ் பண்ணுங்க ரெடியா. ஹலோ டெஸ்டிங் ஹலோ செக் வருதே நம்ம. ஹலோ செக் ஹலோ ஹலோ டெஸ்டிங் ஹலோ ஹலோ. டேய் ஸ்பீக்கர் எல்லாம் கொடுத்துருக்குறேன்.
ஆனால் ஸ்பீக்கர் இதில் வெப்கேமில் கொடுத்துருங்கண்ணா ஸ்பீக்கரு.
அதாவது மைக்ல ஸ்பீக்கர் கேட்குறேன். நான் பேச ஸ்பீக்கர் நான் பேசுற வாய்ஸ் உனக்கு எப்படி எதில் வருது? அந்த ஆடியோல போய் ஸ்பீக்கர் செட் பண்ணு.
டிவிலண்ணா
டிவில சவுண்ட் வச்சு பாரு. நான் பேசிட்டு இருக்கேன், எனக்கு வந்துட்டு இருக்கு, உனக்கு வரல.
அப்படியாண்ணா
உன் வாய்ஸ் இங்க வருது, எனக்கு உன் வாய்ஸ் எனக்கு இங்க வருது.
ஃபுல் சவுண்ட் இருக்கேண்ணா.
உன் வாய்ஸ் எனக்கு இங்க வருதுடா. நீ அதை செட்டப் கிளிக் பண்ணு, செட்டிங்ஸ் கிளிக் பண்ணு.
ஒரே நிமிஷம் இது இதில் வருது சவுண்ட்.
அதான் நீ மாத்தி விட்டு, அதுக்கு நானும் ஹலோ ஹலோன்னு இருக்கு, நீ அங்க பேசிட்டு இருக்கிற. ஹலோ டெஸ்டிங் ஹலோ. அது டிவிக்கு மாத்தி விடு. ஹலோ செக் ஹலோ.
ஒரே நிமிஷம்.
ஹலோ டெஸ்டிங் ஹலோ.
ஒரே நிமிஷம் நான் மாத்துறேன்.
ஹலோ செக் ஹலோ.
கேக்குதுண்ணா. அந்த சாம்சங் இந்த மானிட்டர்
இல்லடா, நான் சொல்றது கேளு. செட்டிங்ஸ் கிளிக் பண்ணு, அந்த வீடியோ கீழ செட்டிங்ஸ் பட்டன் இருக்குல்ல, அதை கிளிக் பண்ணு.
அந்த வீடியோல வந்து வெப்காம் தான் இருக்கு.
ஆடியோ கீழ ஆடியோன்னு ஒன்று இருக்கு பாரு.
ஆமா
அதை கிளிக் பண்ணி ஆடியோ அவுட்புட் பாரு. ஆடியோ அவுட்புட்.
ஹலோ 94
புட்டு வரலண்ணா அதில்.
டேய் நீ ஆடியோன்னு கொடுத்தீங்கன்னா அடுத்து ஆடியோ இன்புட், அடுத்து அவுட்புட் இருக்கு. யாராவது ஹலோ செக் ஹலோ ஹலோ டெஸ்டிங் ஹலோ. எதுல இப்போ ஆடியோ அவனுக்கு எதுல வந்துட்டு இருக்கு? ஆமா. டிவி நீ வந்து இப்போ என்ன பண்ணு, மிரர்மே வீடியோ, இதுல வேற வீடியோ அதுல வேற வீடியோ வருதா? அப்ப என்ன பண்ணு, அந்த ஆப்பிள் பட்டனை கிளிக் பண்ணு. சிஸ்டம் ப்ரிஃபரன்ஸ் இருக்குல்ல, சிஸ்டம் ப்ரிஃபரன்ஸ் ஆடியோவா சவுண்டுன்னு இருக்கும் பாரு அதுல. அது என்ன கேட்டது? அவுட்புட் டிவைஸ். மாத்து. ஹலோ செக் ஹலோ ஹலோ டெஸ்டிங் ஹலோ. சரி, அவருக்கு மைக் கொடுக்கட்டுமா? ரெடி ஆகுங்க. சரி ஓகே.
Hello. Hello.
Hello.
Harish, this is Sandeep.
Hey, hi.
Morning, da.
Morning. How are you, man?
Yes, all good. So, what are you starting?
Yeah. I'm starting TEP now. Bilateral TEP.
Yeah, it's
You guys
bilateral
want TEP or
P-TEP,
TEP? Yeah.
conventional one.
Yeah. So we have bilateral inguinal hernia. So I'm going to start TEP now. First, I'm going to show how to place the main working port. Okay.
Yes, Harish. Go ahead, please.
So this is our retractor here, designed here, just for retraction of hernia. This is retraction of for dissection of rectus and placing the first port. So I'm going to open the inferior border of the umbilicus here and make a 1 centimeter incision. If you want, you can go up to 1 to 1.5, not a problem. But make sure that it's securely closed. I'll show you later how to do that one. So once it is done, I'm going to take this hernia retractor and place and take it laterally. So I want to open the right rectus, anterior rectus. You can see the fat inside here. To sharpen.
Yes.
I
Yes,
want
Harish.
to dissect it now. Slowly as I dissect, I'll go down inside. Now I see the crisscross fibers here. You can see the white rectus layer there.
Yes, very, very well appreciated.
Okay, white rectus. So now I'm going to take the blade and put a small incision on that one. You can see the small incision.
Yes.
ಕೊಂಚ ಕೈ ಮೇಲೆ ಕೊಡುವ.
So Dr.
So once
Harish is
it is done,
standing on right side. He's a left-hand surgeon. So right rectus sheath he is opening. Those right-handed surgeon can do the similar procedure by standing on left.
so now you can see the anterectus, it is opened here. This is the muzzle underneath that one. So I'm going to go as medial as possible, slightly poke inside and open the muzzle. Now you can see the posterior rectus sheath there.
Posterior.
You can see this is the anterior here.
Yes, yes.
The muzzle
Very
has
well
been
said.
retracted and this is the posterior rectus sheath. 10 mm. I'm going to 10 mm port. The pointed edge, I'm going to slide it inside into the extraperitoneal space and leave it there. Most of the time it will securely sit there unless you have made the incision very large. It will sit nicely over there. So now what I'm going to do, I'm going to fix the port. So when you're taking the camera inside and out when you're doing the surgery, sometimes it will come off along with that one. So it's very important that we fix this one. So I'm going to take on one bite on this side and the second bite I'm going to take on this side, right and left. Now in between, the gas will escape when we are doing surgery. So a wet gauze, I want to place it inside here, pack it nicely all around, starting from one side to the midline and to the opposite side.
Yes.
It need not be too wet, just damp also. Damp gauze is more than enough. Roll it, keep it underneath this one and then secure it in place. So it's going to, the incision is going to stay nice and closed. So once this is done, now this has to be fixed to the 10 mm port. So I'm going to fix it to the gas inlet. I'm going to go twice around it and then put a knot. Cut.
So understood? Here fixed.
So
Gas leak is prevented.
now see, it stays
Yes.
without any problem. When we are getting the camera out, it stays in situ and the gas is also prevented from leaking because of the gauze we have placed inside. So once this is done, I'm going to tell sister to put the head down. Sister, head down please. Gas on, pressure 12. 12 is more than enough to do the hernia extraperitoneal space dissection. You can go to 14, but 12 is more than adequate. Now you see the bulge here
Yeah.
developing. Now the gas goes inside and it automatically starts the dissection here. Okay. I'm going to switch off. Let the gas out. I'm going to show you inside how it will look when we put the gas. I'm going to sharpen now. Okay. Now see, we are in the extraperitoneal space. Okay. Now I'm going to open the gas. See what happens when I open the gas. You see the gas is going and it's dissecting already there. Okay.
Yes.
Above is the rectus muzzle. Here the posterior rectus sheath. Okay. In between these two, first I'm going to make a small tunnel here. So when you're doing this tunneling, Clint, it's very important that we stay between the two layers of transversalis fascia. Now I'll show you what happens when we go above the transversalis fascia. See, what you are seeing at 12 o'clock is the supple fascia. If I go above that one and dissect, see, you can see the muscle there now. You see the muzzle exposed here. This is a rectus muscle. If you go above this one,
Yes.
you will be going superficial to the superficial fascia. So then you will not be reaching the landmarks correctly. So now I am going to go in between these two. This is a superficial layer and this is the deep layer below, posteriorly. In between these two layers, you can see this small fibrous tissue here. So I am going to go in this area and then do a small dissection, do a tunnel here, and as I go inferiorly down, I will go and hit the pubic bone. The right ramus I am going to hit because I am on the right side. Now
Got
you
it?
can see the white glistening structure here. Here, see this?
Yes, very
This
nice.
is the bone I hit. Now this is the lighthouse sign. See, if you
Yes.
don't, you can also place the ports initially on both the sides and dissect the Ritzia space completely. But what will happen in the initial stages, if you lose the plane, you will end up either drifting to the right or left. That is why it's called as a lighthouse, because this bone is a fixed structure. You can use it as a landmark to guide yourself to go towards the bone, to the dissection of Ritzia space. So now I have the guidance here. I'm going to make some place for placement of my right hand working port. This is the peritoneum here posteriorly. I'm going to lift the fibers extraparental space, go hit the peritoneum and then lift it up. See, the space is getting created now. I'm going to go posteriorly, hit the posterior wall and then lift it up. So I'm making space here. Now you see the amount of space has been created. I'm going to check again from outside. You can see the right rectus here. That is a tunneling that goes to the right pubic ramus.
Port.
I'm going to place the port here.
Stay close to the posterior.
Yeah. Clean.
In that plane, you don't appreciate much. Just stay close. Two
Camera
layers
from
are
outside.
to avoid your inferior epigastric falling down. If you stay superior to superior layer and expose the muscle, you have all the chances that your inferior epigastric is falling down and coming into your field. Then you have no option but to cut the vessel.
So now I'm going to place my right working port. We have the
Yeah.
rectus muscle here. We are going to go approximately 2 fingers down and 3 fingers laterally. Now you need to judge it in one particular way. You can't always have this one because the right hand working port here has to reach the left ASIS easily without clashing with the instrument. If you go too high, your shoulders will be working well. But then when you come to the opposite side lateral part, your two instruments will start hitting each other. Then it will be very difficult to dissect. So don't go too high. If you go too low, when you place the mesh, the port will come right where the mesh is, causing the folding of the mesh. So now for this case, I'm going to go somewhere here. At the rectus border, I'm going to make an incision.
Can we have an external view, Harish?
I have told them, I
External
thought it
view?
was in. Okay. Now you can see I made an incision here. So I'm going to go here. So the idea is when I'm dissecting towards this lateral side, these two instruments should not clash here. I'll try my best not to clash. If I go here, it's easy to do the dissection, but then placing the mesh will be difficult on this side because it will fold. So I'm going to go here. I'm under vision now. Slowly. See, I can see that thing is coming somewhere there. You can see the pulsation there. Slowly. Camera inside.
Initially, you can do this step by putting it a needle. Otherwise,
Yes.
pneumo at this stage makes it more difficult. Yeah.
So now for working port, once it is placed in C2, you can use two instruments. Either you can use hook, scissors or Maryland. Any instrument you can use, whichever you are comfortable. So I am more comfortable using the scissors. So I am going to start cutting these tissues. Correct. Right now, I'm just concentrating only on dissecting these tissues. I'm not going to do too much of dissection, nor going to do a lot of pushing and pulling right now. Just clear the fibers in front of you. This is all extraperitoneal space fibers. So now we have the bone there. So I need to make my space the radius space. That space I have to create for placement of the mesh fan for the dissection of the sac. So if you are using the hook, go inferiorly and start coming like this. If you are using scissors, you can go the other way around. See, now in the midline, once right side, these loose tissues are here. What I'm doing cutting now. In the midline, you have this fat. You need to cut this fat. When you go to the opposite side, you will find very similar fibers on the opposite side. So these three layers have to be nicely dissected.
Yes.
You see, I'm cutting only one layer at a time now. Only the fat layer I'm cutting now. This is the midline. Now see the opposite side here. This is the midline.
Yes.
This is the right side. This is the left side. If you go too deep here, we will open the superficial fascia and the muscle will be exposed. So once you expose the muscle, you know that you have gone little superficial. So you need to recorrect your exact plane of dissection. Slightly pull the camera back. Only extraperitoneal fibers I am cutting. So posteriorly, posterior rectus sheath and the peritoneum will come now. This dissection I will leave it later.
The elbow is not coming into picture. Now we are in pre-peritoneal plane.
So once this much is done, then I am going to use a camera for my dissection, and then
These 2 layers of transversalis. Midline is already crossed, no? Yes, shown the
midline is
layer of
here.
fat.
See, this is the midline layer here. What I have cut here is the midline.
Yeah.
This is the
So
right
this
side
has-
where I have done the tunneling. This is the midline.
Yes.
This is the left side. So there is a left extraperitoneal space I have dissected here. This is the midline and this is the right side. Okay. So now once on the right side here, I'm going to see this is the peritoneum here. Okay. So all these extraperitoneal fibers here, I will cut and clear it off. And I will make my dissection, blunt dissection here, push the peritoneum away, and I'm going to create some space for placing my left hand working port. Now that is done. Now I'm going to trace from outside where approximately I'm going to place my incision and then check from inside. See, it is going to come somewhere there.
Yes.
Hold.
The bilateral.
See, here again, like Dr. Sandeep said, you can put a Virus needle, check the line, and then place the instrument. So
Yes.
till now the gas was connected to the camera. Now I have connected the gas to the left hand working port.
Right, Dr. Harish. Yeah.
So right now I am in the Ritzius space. So Ritzius space, first, whatever direct hernia is always there in the Ritzius space. So where anteriorly it's got the superficial fascia, posteriorly we have the deep transversalis fascia and the peritoneum, and inferiorly here you get the pubic ramus, pubic bone anteriorly. Posteriorly you have the bladder here, and inferiorly the pelvic muscles. This is the main boundary of the your Ritzius space. Now this transversalis fascia is very important to understand. See, you have the superficial fascia there, and this is the deep fascia. These two layers go here and fuse along the inferior epigastric vessel. When I come into that side, I'll show you now. So I'm going to start the left side dissection first. Monopolar வரல, monopolar connection, bipolar கொடுங்க, cable check பண்ணு. Most of the small bleeds, they tend to stop on their own. But thing is, in hernia, it's better to stop the bleed, especially if you're doing a large indirect hernias. The sac will get bloody, means then it is difficult to identify which is the sac and which is the surrounding tissues.
Yes.
So I'm going to, this bone is giving me a guidance in which direction I have to go. So I'm going to slowly dissect and then cut all the fibrous tissue in the extraperitoneal space. Looks like I'm coming close to a hernia here. We'll see. We'll slowly, layer by layer, we'll open it and see.
Actually, you need to have advantage of height. You can stand up on the opposite side. Yes, yes, yes.
Now you see, it looks like one hernia is there. See, left side direct hernia looks like it is here. Huh? So slowly,
Yes.
what you have to do when the hernia is there, you first give traction downwards, and along this line where the maximum traction is there, you need to dissect here. You shouldn't give a traction here and start dissecting here. Along this line, you should dissect. That is when the hernia and all the layers will nicely open up. See, slowly it's opening up. I'm going to
Yeah.
check the traction again, pull it back again, and then push it back. See, this is a pseudo sac what we are seeing here.
Yes, very well
Pseudo
seen.
sac. Huh? So I'm going to pull it back outside and nicely cut it. Maryland Kudungu. I'll show you what we can do with Maryland and what we can. Scissors I prefer because hernia, all the layers are nicely placed in its location. No, all you have to do is give traction and open the layers. Everything will open on their own. When you're doing with Maryland, you can use it for buzzing and then opening the layer. See, like this. Or you can just tease the tissues like this. This areolar fibrous tissue nicely open up if you just tease it off like this. See, you can use it. You can hold it, buzz, and then split the tissues. But I usually prefer the other way, that is the scissors, because it opens up the layer very nicely. Hook is not a very good instrument to use around this area where the cord structure and the triangle doom comes. It's dangerous because splaying is quite significant in that current splaying. You can injure the surrounding tissues. Slowly I'm giving traction. I'm following the bone. The bone comes here. I'm just following the bone and releasing all the tissues in the extraperitoneal space. This is a medial, left side medial dissection I'm doing right now.
Beautiful dissection, Harish. Really beautiful.
So now I
Harish,
told
there
two
is-
layers. Yes.
Yeah, there is some confusion as far as left and right is concerned. Possibly you are doing right hernia, right?
Left side. See, this is the midline.
No,
Midline.
Your right hand,
No.
right hernia you are doing.
No. Right hand, left hernia. See, this is my right hand. Scissors I'm using. This is my left hand. This is my dominant hand is right side. This is the left-sided hernia I'm doing. This is the right side.
Then we are getting an inverted image possibly then. Scissor is in left hand or right hand?
Right hand. You are getting
No,
it in
no,
left hand, huh?
We are seeing it in left hand.
Yeah, அப்படி ரிவர்ஸ் ஆயிருக்கு. இன்னைக்கு க்ளீன் பண்ணு. பசுபதிக்கு செக் பண்ண வருஷம்.
I was surprised to see you becoming left-handed suddenly.
They're checking, just let them wait. So anyway, in the meantime, so now we saw
Yeah.
about the Ritzius space, no? Now see,
Yes.
this is a superficial transversalis fascia coming here, and that is a deep fascia here. So if I go here, come closer here. You get the inferior epigastric vessel here, see? You can see it here. Inferior epigastric here. This is the inferior epigastric, okay. So now these two layers.
Yeah.
Okay, is it
Yes,
okay
yes.
now? Okay.
Yes, perfect.
So now the superficial layer and the deep transversalis fascia, both of them fuse along the inferior epigastric artery here, vessel. Okay. So this layer you need to break to get into the lateral space. That is the Bogro space.
Yes. Now, mirror. Image.
Image okay now?
Yeah, image is very
Okay.
nice.
Okay. So now I'm going to give traction and push away the inferior epigastric vessel from here. At the same time, the transversalis fascia I'm slightly going to cut and make space. You need to go adjacent, just adjacent to the vessel. Just adjacent to the vessel. Put the left hand and then slightly open up the area. See, the area nicely opens up now.
Very important step.
Now,
Very important.
Now, when I open this layer, I am entering into the Bogro space here. Now, when you're dissecting here, it is very important not to go too high At the same time, identify peritoneum as early as possible. What happens is if I go high here and then start dissecting, I will end up going next to the muscle here. See
Yeah.
there, you're seeing the muscle. I will go into this
Yes.
layer. What happens if
Yes.
you, without knowing, you go into that layer, you come down directly into the triangle of pain and you will expose the muscles. And you will end up placing the mesh right over the muscle, which will cause chronic pain for the patient. So you identify this layer and slowly pull this peritoneum away, and then fat has to be, this Dulux fat has to be pushed to the
Dulux.
lateral side. You see this thing, peritoneum is here, the fat is
Yes,
here,
it's very.
and these are the sling fibers here. Okay, so layer by layer, one layer, we'll start releasing it now.
Harish, Dr. Rajesh Srivastav sir has joined with me.
Yes, good
Hi.
afternoon, sir.
Hi, Harish. How are you?
Hi, sir. Nice
I can see
seeing you
your
again.
wonderful dissection as always.
Thank you. Thank you, sir. See, now the sling fibers is here. Okay, the sling fibers comes here, goes under the cord, and then it's coming out on this side. So, okay, for direct hernias, we don't have to release the sling fibers. If it is an indirect hernia, you have to release the sling fibers and the interfoveal ligament on this side. Only then the sac, entire thing will come out. So now first let's follow the peritoneum. Okay, a little cautery and then slightly push it laterally. Don't pull it down, don't pull it up, pull it, push it away from the peritoneum. It will nicely open up. I'm going to shift the traction again, a small cut with a cautery, and then push away the tissues from the peritoneum. See, I'm creating the lateral space now. Now you see the muscle here and the extraperitoneal space, the fibers are here. I'm going to cut only the fibers backwards like this. This part, it is sometimes what will happen, the peritoneum will get cut here. It is a very important, see this part is, this is where commonly peritoneum will get injured. Even if it's a small rent, it is not a problem. You can put a 3 mm port and continue the dissection. Okay, now see again. We have the Dulux here, the peritoneum going here, the cord structures going here. This is a transversal sling fibers coming here, inferior epigastric. So now we need to separate the peritoneum from the surrounding structures now. I'm going to lift the peritoneum and then slowly start swiping away the tissues. Either you can either use hook or you can use you can use either Maryland or scissors, whichever you want you can use here, whichever you get comfortable with you can use.
This side, this is the right plane. Little bit below the palmer's point. And it's always a good practice if you are placing a 5 mm port at the last, put a telescope and see. Mostly there is no injury, but you just check.
So we'll slowly develop the layer one at a time. This part of the dissection is very important because if there's a large indirect hernia, you are going to place the mesh at least 5 centimeters. It's going to come like this here and then tilt. It's going to bend over this one here. It's going to fold. The mesh is going to fold and the peritoneum is not going to get cleared. So this area of dissection is very important and you need to get this peritoneum away from the field of mesh. Okay, now it is come out because it's a direct hernia. I will not be coming too lateral. Now I'm going to come to the medial dissection. See, from the left hand, I'm going to pull it away. You can see the cord structures here. The vessels are here. We'll see the cord will be somewhere in this plane here. We'll check for that. With the left hand, I'm going to do a blunt dissection. This plane is nicely going to open up if you give a good traction here. Bipolar. Bipolar. Putting it. Scissor. We'll slowly give the traction and dissect away, and this tissues I'm going to open it up. Here, iliac vein is there. You can see the blue color here, iliac vein. Don't be very into and go and dissect in this area. You need to give a good traction, take all the tissues away. With the left hand, you need to separate the vein, push it away from your operating field. Under vision, where you can see very clear fibers, only those fibers you need to cut. Be very careful in this area, because if it bleeds, it's going to be very difficult to manage there. Now inferior, what's the extent of dissection? Come here. Can you see the nerve here? See here, nerve? Operator now here. Once this comes into view, this is the inferior extent of the dissection. You don't need to go underneath that one, and you have try not to expose the nerve. Let this tissue always be there over the nerve when you're doing the dissection. So once that is done, now I'm going to tackle the peritoneum here. See, the peritoneum edge is coming like this, and it is going down here. So I'm going to tackle the peritoneum. Ported வெளியில கொஞ்சம் தள்ளி நில்ல, கை ஸ்ட்ரைட் பண்ணிக்கோ. So what you can do dissection here, either you can hold the peritoneum, lift it up, make some space here and push it away, or alternatively you can hold the cord structures and give a short buzz here, camera closer, and then swipe away the peritoneum. There are two ways of doing the dissection. As and when the situation requires, you can use both of them wherever you want. Sometimes the fibers will be very tough, so sometimes you may use both the techniques wherever is required. Now you can see the cord has come into the picture. I'm not going to handle the cord. I'm going to stay as away from that as possible. Again, with the left hand, I'm giving traction. With a blunt edge, I'm just pushing away the cord. Again, continue the traction and then release these fibers. Now see, the cord is turning inside. No, this is the medial extent of the dissection. Until this ligament, it's the medial extent of the dissection. And then the final part is the paratalization of the peritoneum. See, there's a small rent in the peritoneum. So what to do now where there's a peritoneum rent is there? Should we get bothered? Should we, what to do? So you don't have to bother at all. You can just let the air go inside, let the abdomen fill up, and then put a 3 mm port and release the gas. In pole. So there's a very tiny hole. Gas has not gone inside. If it goes, I will show you how to put the 3 mm incision.
Usually at this stage, gas doesn't bother. Yeah. Now
Yeah.
dissection is over, so
Almost. No, opposite side is there, no, sir. Still.
it's only in the early part of surgery. If there is pneumo, then you need. Now dissection is already done, so usually at this stage you need not to put opposite side just below the power point, below the power point.
See, now we have created adequate space for a direct hernia. See, paratalization has been done. Now, I'm just showing you the main important structures here. See, this is the cord.
Yeah, if you can check, you should check at the last.
Can you hear? Transmission irka? Okay, this is the cord. These are the cord structures. This is the peritoneal edge. This is the triangle of.
Yeah,
Okay.
beautiful.
If you go deeper dissection here, you will get the iliac vessels there. So that is a very dangerous. So you should not go deep to that one. And you see the iliopubic tract will be here.
Yeah.
Okay, it will be here. Let's consider this is the line of iliopubic tract. This is the
Yes.
cord structures. Let this side.
Yes, sir.
This is the peritoneum. This is the triangle of pain, and your nerves will be running here underneath this one here. So if you go in this plane and come here, you are going to make this fat layer come on this side, and you are going to expose entire muscle. Then you are going to place the mesh on the directly on the nerves. You can see the nerves going here. See.
Yes, we can very well appreciate it. Yeah.
So this is almost complete of the left-sided dissection. Only the medial part I have to see where the peritoneum is. Once that is done, a complete dissection will be over. Maryland kuda. Sometimes scissor will not work. Sometimes you may have to use Maryland. So all these are different instruments you can use. Whichever is convenient at whichever point, you please use that one. Make sure that you demarcate and see the peritoneum very nicely, because when you are placing the mesh, the peritoneum should be well at least a centimeter away from the mesh. So I think this is more than adequate space for our left-sided
Yeah.
mesh. Now we will go to the right-sided hernia. Scissors kudanike. Kudi. Ma monopolar koncha kaal inda pakka kuduma. So like we said, now left side is over, right side. See, looks like there is a direct sac on this side to here. This is the right pubic ramus here. So this is the midline. Symphysis here is the midline. This is the right pubic ramus. Right adjacent to that, you have the right direct sac. So first I'm going to make a little space on both all the sides and delineate the sac first, just for better understanding. Otherwise, we directly go and deal the sac right now. Huh?
Yes.
See, now you can see the sac. You can appreciate it slightly better. See, this is the sac. So what I'm going to, I told you that I'm going to pull it out nicely and slightly give a small buzz, and then look for, see, pseudo sac has come here. Huh?
Pseudo sac is visible.
I'm going to push it. This is a avascular plane. You can just push it away like this and it will go off. Huh? See, it's a avascular plane. But very
Yes.
important is you need to have a good traction when you are doing this one. Camera sharp. When you're doing like this, you transfer the traction from one hand to another hand. Every time if you leave, tissues is going to go back to its original location again. Huh? So keep on, learn to transfer the traction from one hand to another. If you're using Maryland, it's more easier. When you are coming again on the medial side here, you have to be very careful. This is the corona mortis. It was not very prominent here. You can see prominent veins here. Sometimes it will be even more prominent than this. Here the transverse running branches are there. Here it is very dangerous. If it gets injured or cut, no, this vein will get retracted inside and there will be continuous bleeding from here and above and below from both the sides. So it is very important when you're doing medial dissection, try not to injure that one. Bipolar. So in the early stages, if you have little fear, what you can do is, first only you can use a cautery and slightly buzz the surrounding areas. Okay. Yes.
Harish, there is a question.
Yes.
What should be done to control a bleeding in corona mortis?
In corona mortis, best would be not to get into that situation. See, best would be when you're doing here, no, when you give traction here, pull it back. This tissue, these layers open up. First, you need to go only in this layer, slightly open up and then go. Once you see the vein, stay away from, stop the dissection there. Because your Cooper's ligament is here. You don't need to go and dissect anything over here to this one. Once it bleeds, only option is you have to immediately catch it with your hand and give a bipolar and you have to stop that one. Otherwise, nothing else can be done. It is very difficult because it retracts very down. You need to dissect down here and then go and bipolar it. That's the only thing we can do there. These transverse vessels, you need not do it because I am planning to plicate the sac. See, this is a large sac. I am planning to plicate it. That is why I will be fixing it to the medial part of the Cooper's ligament. So when I am taking a bite here, again it will start bleeding. So briefly, a small buzz I will do here, cauterize, and then proceed with the surgery. Pudima. So now the right-sided dissection is done. Right-sided sac is reduced. Now I am going to do the rest of the dissection. Identify the inferior epigastric. See, inferior epigastric is here, no? Now follow this layer. This is the superficial layer, no, of transversalis fascia. Now let's say hypothetically we have come from above like this in this area and this layer falls down. Inferior epigastric artery also falls down. So you will find the inferior epigastric artery lying on the floor of the peritoneum here. If you go above this layer and come, then after that dealing with that is very difficult. Placing the mesh is very difficult. There, of course, if you get into that session, what you can do is you can do a transfacial 2 sutures with ethylon. You can take, lift the vessel up and keep. At the end of the procedure, you can just remove the transfacial sutures. That's one thing you can do. See, inferior gastric, have to be very careful here. So I'm going to go just adjacent to the inferior epigastric and slightly start dissecting the tissue and see where the peritoneum is and where the dulux is going to come. Slowly by layer, I'm going to push it and see where it is going. See, the peritoneum looks like it is here. Transversalis fibers are coming like this. So I'm going to cut this and make little more space for dissection. Not necessary you have to stick to one place. You can do little bit dissection all around to get into the right plane. So it should not be like I do dissection only one part at a time and then I will go to the next part. You do here and there, slightly make little more space for your movement of your hand. See, the peritoneum is going there down. So I need to separate this away from here, from the cord structure. I'm going to hold the peritoneum, pull it back, and then slightly, slowly start pushing it away. And then transfer it again to my hand and then separate it again. See, slowly it is getting separated. You see the sling fibers are coming here. The cord structures are going here. I'm holding the peritoneal edge. This is a lateral anterior fascia. That is the dulux fascia here.
You can see the shiny dulux fascia which was highlighted by Dr. Harish.
So I'm going to separate the cord and structure. The peritoneal edge is here. And these are the tissues I don't want. I'm going to cut it here and go along this plane. A short buzz and then swipe away the tissues. Transfer the traction to the next hand. And then again swipe the tissues away. This is why most of the time it is better first to learn TAPP, because in case when you're doing TAP, some bleeding happens or some air goes inside, then you're not able to proceed. TAP is always a very good fallback alternative. Should not be under the mindset that only one procedure is there. TAP is also a very good procedure for beginners and it is a must know for everyone who wants to do inguinal hernias. Don't go too deep here until you see the muscle. You will cause lot of bleeding over there. So now you can see the layer again. Cord structures are here. The peritoneum is here. I separated the peritoneum. The cord is going down here. So again, I'm going to separate the cord and structures from the peritoneum slowly. See, now when I'm going here, this part is hitting my hand. That's why it said you don't have to stick to this part all the time. Now I want to tackle this part and then again come to medial dissection again. Only for this part, it is better to use the hook. Rest everywhere in inguinal hernias, either it should be scissors or it should be Maryland. Only this part, the hook will work very well. This is another place where easy to put a hole. So you can see the peritoneum lining here, and I'm going to only cut that tissue with traction. Just come along the straight line, it will nicely open up that plane. All these layers, tissues have to go away. It should not be inside on this side. Back here, this place again is, I told you, it's very important to dissect this area because the mesh should not fold here. At this time, you can ask the sister to slightly pull the instrument back, the port back, so you can make little more space here. Okay. Gas clean. I'll clean the camera once. See now, this is this is adequate space I have created for mesh to sit there. It is not going to cause any trouble now. Mesh is not going to get folded. Scissors. So now my little more space has come for my right hand to move around. So I'm going to do the paratalization. Come back to the paratalization again now. Slowly lift it up, go along the edge of the peritoneum and push the peritoneum away from here. Young male patients don't do this because it's 67 years. I'm taking a slight liberty to use cautery close to the cord, but in a young patients, it's a no-no.
Harish, age can be just a number.
Yeah, I know. True. I know. Very true. But should you help them at this age? Okay. This looks like adequate dissection for now. If requires, I will do little more dissection based on the size of the mesh I am taking. Okay. See, now both the sides hernial dissection is complete. This is also adequate.
Beautiful.
Okay. So now final thing remaining is to deal with the sac. See, left side it's a very small sac. When you put a mesh, it's going to sit nicely over that. It's not going to create trouble. The right side, the hernia is quite big. That it's still a controversy whether it will help, whether steady cell seroma may not be much make a difference, or recurrence rate may not be there. But then it's always safer you plicate the sac if it is this big, because with if there's a medial defect means there is always some kind of collagen abnormality tend to be there. So you don't know whether the mesh will hold well or not. Sometimes we have seen mesh completely going inside the defect when they come for recurrence.
Yes,
Sometimes
yes.
this thing. So it's better to plicate and give a flat surface for the mesh to sit.
Agree. Agree.
Come, children. You just see from outside how it looks now. Once the gas has gone inside into the sac, see, this is the hernias. Okay.
Yes.
Kuduma.
So how you are going to plicate, Harish?
See, I'm going to use a non-absorbable suture now. I'm going to prolene number 1. I'm going to use 10 prolene. So first bite I'm going to take through the medial part of the what is that, Cooper's ligament, and then going to go all around from 3 o'clock, 12 o'clock, 9 o'clock, and then come back through the Cooper's ligament again, and then fix it to the Cooper's ligament. No problem.
Pseudosac.
So first will be the reverse bite I'm going to take. Once it is done, I'm going to temporarily park it here, and then wait 1 second. I'm going to go to the apex here and then pull it out, and then see how much I have to get outside. See, this much is enough to get it outside and keep here. Okay.
Fine,
if I get it too much outside, it's going to cause traction. Not only that, and the mesh is going to stay lifted up. I just need it approximate one a flat surface for mesh to sit. So that's all. Once I get this position, then I'll ask sister from outside to press it and keep. See, once she presses, no, I can leave this hand freely. It will not go back inside. Avlo press panna. Koncha kammi panna. Apdi pudi. So either way, what I'm going to do, usually I don't leave the hand like this. Okay, that is why I park it so that I can take the stitch directly there, and then from there I go at 3 o'clock, and then take one bite at 12 o'clock, and at 9 o'clock, and then only I'm going to leave. Immediately invert the suture there itself, hold it reverse, pull it up, and take one at 6 o'clock position. Once that is done, I'm going to come out from there. Closer camera. Now she has to hold and keep. She should not leave now. Huh? So just before taking the bite, what I'm going to do and see if it is adequate. I'm going to hold both of them. Keep it tight. See, this is more than adequate. Okay. If you want, you can take one more bite later. Koncha taluma. So let the track this her pressure be there. scissors kodu manake. This is okay. You don't have to worry about this because once gas goes out, they all fall together and stay in, become flat here. Too much of pulling inside is not required. There are some people who say the cord, this sack has to be fixed to the rectus, but rectus is not a hard structure. With the traction, it can cut through, but it's always safe to find a fixed structure to place the sutures like this. That is Cooper's ligament. Preferably, I prefer on the medial side because I'm going to take the mesh fixation here. See, for example, in this case, bipolar kodu manake. First enak right side mesh kodutire. Kodima. See, now I'm going to take bite very close to the this vessel. So I don't want it bleeding after this one. So I'm going to just slightly cauterize this one. Because once the mesh overlaps, sometimes you cannot see what is underneath that one.
Agree.
12. Huh?
So which is a mesh which you are going to use, Harish, now?
We are going Trulin mesh, polypropylene. Trulin. We are going to 12 by 18 is the size of the mesh. Now 12 I am going to keep constant because adequate dissection, and 12 is more than adequate. I mean, it's going to cover everywhere. And width wise, I am going to cut it to 17. 18 if I take, it will come and sit on the left side defect. So I will go to 17 and keep the mesh. 12 into 17 is going to be the size of the mesh. From 12 by 18, 1 centimeter width I am going to cut now. You can keep full size mesh also, it is not a problem, but this is adequate for now. Show. Velili kami. 12, 17 more. If you want, you can always do a little more dissection later. Now see how she is taking the mesh. So she is using the glove cover and she's kept the scale next to it, and then she's measuring and cutting the mesh. And she's changed the gloves. And I am not going to touch the mesh in the entire process. She is going to do it, and she is going to get that mesh along with that gloves cover and keep it. And I'm going to use a needle holder and push it. No point of time, mesh is coming in contact in my hand. The entire thing is handled by a fresh gloves and by the sister. Now she is cutting that round edge. What she has cut is the lateral part. Next, she is going to give a small bladder cut below. And then see how she rolls the mesh. The both edges she will invert inside. So as soon as I go and leave the mesh, it will just open up in its place. Okay. Now she has held that one with the paper. She is going to come. I'm going to take the needle holder, and I'm not going to touch the mesh. I'm just taking the edge of the mesh here, and then open the wall of the 10 mm and push the mesh inside. The entire mesh goes inside with only contact with the sister. Okay. Clean. Gas போயிருக்குல்ல இல்ல போட்டுக்கலாம் இல்ல மெஷ் போடும்போது ப்ராப்ளமா. So now what I'm going to do, I have to place the mesh. It's very simple. I mean, it looks simple initially, but then with practice it will come. The lateral part, just leave it there. The upper part you hold in your hand, lift it backwards, and this open it like this. It will go and sit in its place. See?
Nice.
Just pull it lateral. Open the mesh. Make sure that its edge is at least a centimeter away from the peritoneum for safe. See, it's covered in all the direction well, and well below the pubic bone it has gone. Come down here, go under the mesh and come down. See, well under the pubic bone. Because it's a direct, more prone for recurrence. So we have to be doubly careful and nicely cover up that area below the this one. She doesn't have a direct sac. I mean indirect hernia. So I'm not really bothered about covering too much on the lateral side. I give little more preference on the medial side. Okay, now it is nice and sitting well here. This is more than adequate coverage. I'm going to take this side. Now I'm not going to fix right now. I'm going to place both the mesh, see, and then fix. Before taking the mesh, I'm going to ask my doctor to hold it like this so that the next mesh doesn't go above this mesh. Same size. For 3 mm கூட எனக்கு. See, there is a gas gone inside. When I'm placing the mesh, what will happen? The peritoneum will get pushed anteriorly towards the mesh. So then it's not going to sit properly. So I'm just taking a 3 mm and letting the gas out now. See, this is the outside view. இது இங்கே focus பண்ணுங்க. This is a costal margin. Just under the 2 centimeters below that, I have taken the 3 mm port here. Ready? Good. First, I'm going to point it downwards and push. The back posterior rounded part of the mesh, I'm going to turn and place it in the lateral side. So one part of my work is done. ಅದು ಬಿಟ್ರೆ okay. So this is the right upper part. This right angle comes at the upper part. So I'm going to take it its location, then flip the mesh around like this. Again, same, just go below the pubic bone, sitting nicely here. I would prefer little more coverage on the medial side because it's a direct sac. This is more than adequate coverage now. Back, show me, come little back. Yeah. Now see, nice 3-4 centimeters midline overlap is there. The final part is fixation of the mesh. First, whether you need to fix, yes, it is better to fix the mesh because we have seen many cases of TAPP migrating into the sigmoid and migrating into the bladder. So yes, you have to fix it to the Cooper's ligament, which is a nice fixed structure. Nice thick bite over the Cooper's ligament. If at this point when you are placing the suture, if your hand is not going inside, if you need to struggle, that means you are hitting the periosteum. So reposition and look for the ligament.
Very well do it. If you ask me, PDS is the biggest.
Pudima?
You just want the fixation for a few days. If mesh is incorporated in the body, then there is no use of this.
So once the left is in, I'm going to fix the right side now. Back. என்னாச்சு நீ வெளியில வா அப்படி இல்லை back. Back. Make sure that mesh is sitting properly. Even if you have to take 1 or 2 attempts, you don't want a folded mesh. Sometimes the angle doesn't come properly. You can always use this particular technique of taking it reverse bite. Come here. Sometimes that pubic bone angle and the needle angle may not match properly. Hey, ulla va, kila va. So So if the mesh is falling down, ask your assistant doctor to come under the mesh, get the camera under the mesh so that it will sit on the mesh. The entire procedure I have used a 0-degree camera. After the initial tunneling, you can immediately change it to 30 degrees if you want. At the beginning of the procedure itself, because we are used to using this one camera, we use only 0-degree. It's your wish. Now this fixation to the rectus is optional. These two fixed location at Cooper's is a must. It is good. Rectus is optional. If it is nice, if you can put, but in case any situation you are not able to put, you don't have to get worried. At least two fixation is nicely sitting. Make a nice thick bite. Every time when you pull, make sure that the mesh is sitting properly until you take the bite.
Yes.
Just let it sit there. Don't make it too tight in the first sitting itself. The second one, when you're taking, make it tight and it will sit nicely without causing too much of pressure on the muscle. Scissors. Pudi. So now let's inspect the from one edge to another one. See the left side. So it is sitting nicely here, well away from the peritoneum. See here where the peritoneum, show me the peritoneal edge, it sits somewhere here. So approximately about 1.5 centimeters gap is there. This is another important point again. See, this is where I finally dissected it. Sometimes when you're using an indirect hernia, is there large indirect hernia, what we do, we tend to keep little more laterally, give little more extra covering on the lateral aspect. So that time, if the peritoneum is here, the mesh will come and tent over here in this place. So you need to nicely release this and make one straight line here for the mesh to sit nicely. The same thing, we'll check the other side. Other side also we have good amount of space on all the directions and sitting well also. So with this in situ, first I'm going to do is remove the needle out. He will follow me until the end. Until you see the needle has come out. I'm not going to disturb that area. Try to push back the instrument through the same hole again. Now what I'm going to do is hold the medial aspect nicely, make the mesh sit nicely in its place like this, and then fix it there. Show me the left side, and again I'm going to make sure it's sitting properly and then make it nice and taut here. Okay, it's nicely sitting. Now I'll ask sister in the right side coming, ask them to slightly deflate now, deflate the abdomen, deflate the extraperitoneal space now, deflate. Deflate பண்ணு, கேமரால இருந்து ஓபன் பண்ணு. ரைட் சைடு காமி எனக்கு. பண்ணு நீ deflate பண்ணு. The entire thing is sitting in its place now. So once that is done, because the gas had gone, if the gas had not gone inside, we don't go inside and check again because we have stuck to the extraperitoneal space. But now we have put a 3 mm port inside. So now I have to go and inspect it. Gas connect பண்ணீங்க. Now I have to go and inspect the intra-abdomen to make sure that 3 mm has not poked anywhere inside.
I think that's very, very important step. Now he is going transperitoneal.
Gas to 3 mm. So gas is going.
Can you show வெளியில இருந்து கம் இது இங்க இருக்கட்டும் இங்க இருந்து காமிக்கிறேன். So now see, this is the 3 mm port I had put in the right hypochondrium.
Yes.
Now remove the gas from the left hand working port and I have to put into the intraperitoneal. Now see, the pressure is increased. My pressure 14 போடுங்க. Intra-abdominal I'm going to go to the pressure of 14. அப்படியே மேல பண்ணுங்க.
10.
So scissors. So now I'm going to do is I'm going to cut this.
You can use same telescope.
You don't have to change the to 5 mm. The same thing I'm going to use, and then put the 5 mm obturator inside, pull it back, and then go inside. You can hear the gas coming out.
Yeah.
Clean kudunga. Now see, I have closed all the ports, extraperitoneal space, both the ports I have closed. Now I'm going to go intra-abdomen, I'm going to go there and then open the port. See, the gas slowly gets sucked out now. See, now
Beautiful.
nice, the mesh is sitting there. This was the defect which you had reduced, the large direct defect. The mesh is nicely sitting well away from the defect. More than 5 centimeters coverage we are given. Finally, you need to first inspect where you have put a 10 mm inside. Concentrating 3 mm, don't forget the 10 mm inspection. See, this is the 3 mm which we have put here. Muzzle, everything is looking good, no problem. Now what I'm going to do from outside, before deflating, make sure this is open, 5 mm. This is in the extraperitoneal space. This and this working ports and the extraperitoneal. Keep the gas open. So even if there is a small rent, the gas leaks again, it will come out through this one. So now with this in place, I'm going to deflate the abdomen now. Gas is the I'm removing the 3 mm. Work is done. Remove the head and all the gas is let outside. Until then, this 3 mm port is kept open here. So whatever gas is there, it will escape outside. So finally, I'm going to just squeeze out all the remaining air, and then our procedure is done. Finally, we are going to close the anterior rectus here. Idu kudu, Alice kudu first.
It's in front.
Kudi. I'm going to take 1 or 2 bites in the anterior rectus. Kudu. Put it. See the inferior margin of the anterior rectus which we have cut. Put it. ரெண்டுமே புடியது அப்படி புடி டூத் கூட எனக்கு.
So I think it's done, Dr. Harish.
Yes, we are done. I'm just closing the abdomen. You can call it a day. Okay. Right.
Thank you very much.
Right.
Excellent demonstration.
Thank you. Good.